So I want to thank the organizing committee for the opportunity to present. It's quite an honor to be part of this group. I'm actually going to sort of maybe be the lightning rod that Ajay was talking about, where moderating among the different types of consensus or the different types of guidelines. And so in the next 15 minutes, I'd like to go through that. Now, I have no financial disclosures, but I will say that I'm a member of the IAP Guideline Committee and of the European Guideline Committee, but I did not participate in the AGA Guideline Committee, so you may detect a bit of bias in there, and so you'll see that that there is some differences among these different groups. Now, this is the problem. It's a very common problem. As Ajay pointed out, it probably represents about 3% of the CT scans. Somebody gets a CT scan for abdominal pain, and there's an incidental finding of a cyst. We know that these cysts represent a spectrum of disease ranging from completely benign to frankly malignant. Most importantly, the mucinous subtype of cysts are precursors to invasive cancer. Now, although they're precursors to invasive cancer, not all IPMNs or MCNs progress to cancer. These are data from Peter Allen's group, which demonstrates that a 5-year risk of IPMNs progressing to cancer is only about 3%, which approximates the mortality of a pancreatic duodenectomy done at most institutions. So every time we see one of these cysts, we balance missing a cancer by not operating and preventing a cancer-associated death with operating and causing a potential mortality or even more significantly, long-term morbidity. So how do we go about this? Well, really, if you think about it, what Ajay is presenting is the future, and that's where we're heading. But in the present, and going back to when the guidelines were first developed, this is really all we have to go on. Patient history and demographics, so is it a young middle-aged female, is it an older male, which actually gives a lot of information. Imaging characteristics, and these are not functional imaging characteristics, these are morphologic imaging characteristics. So the appearance on cross-sectional imaging or on an endoscopic ultrasound. And we also have cyst fluid analysis, with the most generalized and widely used marker being CEA, as well as cytology. So let's go through these different modalities. Well, imaging, I could give you the numbers on the difference of being able to discriminate between a serous cystadenoma and an IPMN, probably the most common thing that we do. But I'll just show you this example. If I handed you these two specimens and you looked at them closely, you could hold them in your hand, you could look at them with your loupes. Would you be able to tell the difference between these two morphologically when you're looking at the actual specimen? I mean, I can't. So one of these is a benign oligocystic serous cystadenoma, and the other one is an IPMN with high-grade dysplasia. And you can see here that although they look very much alike, they're very biologically different. So how would you expect, if you can't differentiate by looking at them directly, that a morphologic imaging test is going to differentiate between the two? Similarly, the accuracy of cyst fluid CEA in differentiating among serous and mucinous is only about 79%. And the accuracy of cyst fluid analysis, or of cytology, in the general population, I know it's different at some high volume centers, but the accuracy is about 59%. So that's what we had to go on back in 2006. It's still what we have to go on when these guidelines were developed. And basically, all guidelines are based on those things and looking at the data in different way. So if you go back to 2006, Masao Tanaka and Carlos Fernandez del Castilla recognized that there was a large heterogeneity in the management of these cyst types and endeavored to put together a group of experts to study this. And that was done in 2006. They met at the IAP meeting in Sendai and came up with the so-called Sendai guidelines. In 2012, these were modified. The Sendai guidelines were very safe. They had a high negative predictive value, but a relatively low positive predictive value, so that no cancers were really being missed, but they were relatively nonspecific, and operations were being performed that were deemed unnecessary. So some modifications were made. We created two categories called worrisome features and high-risk stigmata, and they came out with the new 2012 guidelines. Then, and now those are also known as the Fukuoka guidelines, which still really are the main guideline today in the IAP group. Now, they met again in Sendai, and in Sendai in 2017 or 2016, and there was minor modifications made, in particular added SYM01.2, did some more detailed work on solid component by Roberto Salvia, who will be presenting here, and they basically refined the Fukuoka guidelines, but they exist as they were created in 2012. Now, not really so much as a competition, but as the recognition that the Fukuoka guidelines or the IAP guidelines were very much directed toward IPMN. The European group wanted a more broad-based guidelines, so Marco Del Chiaro put together a consensus group back in 2013 and published this work. And then recently came to the realization that there was much more literature on the topic, and got the group together again, a more broad group, and did a more extensive literature search, which I'll explain, and came out with the recently published European guidelines. Now, the AGA came out with guidelines in about 2015 based on the premise that we were over-treating and over-following, doing too much for these pancreatic cysts, and that the vast majority were benign, and that's the premise. So now let's look at the details. Well, here are the Fukuoka guidelines, which were then again modified slightly to become the modified Fukuoka guidelines. The method here was an extensive literature review, assignment of topics, and convening a meeting and a symposium where everyone presented, and it is admittedly a consensus of expert opinions based on experience and based on literature. Well, why consensus? Because we concluded that the vast majority of data are retrospective and uncontrolled. So we have to add a good bit of judgment and intuition to flawed data. Now, the European guidelines that were recently revised, or recently published, they tried a bit of a more scientific approach called a grade technique, where they basically had a series of questions to be addressed. There was assignment of literature, an extensive literature assessment was performed, and then the ability of the data to answer the question and the strength of the data were graded to make several statements. And these were considered to be, even in the title, it's evidence-based, but I want to point out that the final decision of the statements were actually a consensus vote. And that's not a negative statement. The authors in the group recognized that the data were relatively weak in almost all cases, and that intuition and consensus and experience would need to be added to the guidelines. And they concluded that multi-center studies are required to provide the necessary evidence to guide management. Now, the AGA published two papers. They published a technical review, and they also used a grade method, and they were very rigid, and that say that this was an evidence-based method. It was, actually, and they concluded the following. In this technical review, we attempted to evaluate the evidence for diagnosing and managing pancreatic cysts. Unfortunately, there's insufficient evidence to make definitive recommendations. Some say they should have stopped there, but then they went ahead and made recommendations. Now, really, they also used some judgment, but again, judgment based on a different premise, judged on the intuition that we were over-treating these things. So, if we have insufficient evidence, how can we make evidence-based guidelines? It's really not possible at this point in time using the information that we have. The fundamental tenet of evidence-based methods is that it requires high-quality data. There's an old saying in computer programming, garbage in and garbage out. The output can only be as good as the raw material that you put into it, and right now we have relatively low-quality data. Now, that's not to say that these guidelines aren't important. They're the best thing that we have, and they actually have improved the care of patients with pancreatic cysts. But these guidelines are based on some evidence and a lot of experience and a lot of judgment. And right now, that is the best thing we have. Like I said, this is the here and now. To answer Dr. Windsor's question, what do we do in the next 12 months? What Ajay is talking about is the future and will certainly improve management. So let's look, there's many aspects that we can look at these guidelines. We can look at the decision to follow, how to follow, all these things. But what I think is probably one of the most important things, in particular for surgeons, is this balance between observing and resecting. And let's look at the differences in these outlines and the similarities. Now, a lot is made about the differences, in these guidelines. But I want to point out that for the majority of patients, there's actually complete agreement. So if you look at MCNs, mucinous cystic neoplasms, all three guidelines recommend resecting. Solid pseudopapillary neoplasms, relatively rare neoplasms in young females, all three guidelines recommend resecting. Main duct IPMN, again, we'll get into some of the details, but in general, all three guidelines recommend resecting. For the AGA guidelines, they need an additional feature, and that is a pretty big difference. For mixed type IPMN, so dilated main pancreatic duct, again, the recommendations for the most part, again with different criteria, are to resect for the IPA and the European guidelines, and the AGA is yes if you have a second feature. Now let's look a little more into the details. So if you look at the absolute indications for surgery and compare the three, you'll see that for the most part, the IAP and the European have very similar criteria. Symptoms including jaundice, new onset diabetes for the European criteria. In the AGA only is commenting on non-symptomatic cysts, so they exclude that and say that those need surgical resection. So in other words, they're really in agreement too with what is being said. Now there are some differences in the detail. You'll see that the duct size is a little bit different between the IAP and the European. However, you'll also notice that in the relative indications for surgery, that the ones that are in indications for surgery for one are in the relative indications for the other, and again, the AGA requires two. So the point being is that if you just look at these two categories as relative and absolute indications, there's a lot of area of agreement. There's concern and a tendency toward resection for symptoms, jaundice and pancreatitis, for enhancing solid component, for duct size greater than 5 millimeter, for cyst size greater than 3 centimeter, for rapid growth, and for positive cytology. Now, how that's defined is different among those three groups, but there's agreement that those are concerning. There's also agreement, even with the most aggressive criteria, that relative indolence of small side branch IPMNs with no solid component. In other words, the malignant potential in those are very low. Now, there are some gray areas, and let's point, and I could go through numerous examples, but let's point out some of the gray areas that fall between the different guideline criteria. So duct size is one of those. So a 6 millimeter main duct IPMN with no solid component, no second finding. If you look at the IAP guideline and interpret it, you could interpret it as observe or maybe resect, because it is one of those secondary criteria for resection. The European guideline, which is now above 5 millimeters, would have you resect this, and the AGA guidelines, if there's no second feature, which there isn't on this made-up case, would have you observe. On the other hand, if the duct's 10 millimeters, IAP would say resect, European would say resect, and the AGA would say observe. So there are some differences. There's another gray area is in cyst size. In the original Sendai criteria, there was a size for 3 centimeter cutoff for side branch IPMN. Some of this work I think is going to be presented by Dr. Zhang here, and actually we made some changes based on some of his work. But a 4 centimeter side branch IPMN with no solid component, the IAP would currently say observe that if it has no other concerning features. The European guidelines would say resect that, and the AGA guidelines would say observe. Now, if we drop the size to 3.5, the IAP would still say observe, the European would observe, and the AGA would observe. So slight differences. So there's other gray areas too. Some things are not commented upon by all groups. So new onset diabetes, duct stricture with atrophy. I think that these two things are important and play in my judgment on what to do with patients, but they're not commented on by all groups. Thickened cyst wall with septations, family history, and smoking, things that we know are associated with increased risk of cancer. Now, are there some major concerns? Well, I will say that with the AGA guidelines, there are some major concerns that I think is counter to the current evidence that we have. So AGA recommends the discontinuation of surveillance after 5 years of stability. Well, this is completely in counter to numerous studies that have been reported, including our institution, and shown here as a meta-analysis, which shows that the risk of cancer increases over time. If anything, the surveillance should be increased over time, not decreased. So that is something that I think is absolutely wrong with one of the 3 guidelines. So to close, which one to use? Well, it's philosophical in this balance of missing a cancer and performing an unnecessary operation. What would you rather? Would you rather miss that cancer or perform the unnecessary operation? In other words, there's a tug of war between the sensitivity. We could get 100% sensitivity by operating on every single person with a cyst. Now, we're not going to do that. And we would do that at the loss of specificity. We could get very specific if we only operated on people who had blatant cancers. The truth is somewhere in between in the way that we need to manage these, and where you fall on the spectrum depends on where you on your philosophy and what you choose. So pretty far toward the higher sensitivity, the more aggressive guidelines, which have the lower duct size and continue to have size for side branch IPMNs, are the European guidelines. At the other end of the spectrum are the AGA guidelines. The first Sendai guidelines used to be pretty close to the European guidelines. Because of trying to increase the positive predictive value, there was a slight shift toward a higher specificity. So let's look what it resulted in by doing that. So there's several studies that looked at this change in the Sendai to Fukuoka guidelines. And in this cohort of 563 patients with branch duct IPMN, 76 Sendai negative patients underwent resection, and 7.9% had high-grade dysplasia. When we dropped the size threshold, high-grade dysplasia was eliminated, or was increased to 17%, but 1 case of invasive cancer would have been missed. So trading off sensitivity for specificity, or specificity for sensitivity. Others, though, have shown that there's really no difference. So comparing in the final data that I want to show is there's a head-to-head comparison of all 3 guidelines by the Dutch group, okay, which I think is a relatively well-done study. This is before the recent addition of the European guidelines, so it's the older guidelines, but they're very similar. 115 patients underwent resection for IPMN. An operation, and these were just used basically on the local criteria. Now, if you use these and applied the guidelines to this population, the AGA would have avoided an operation in 28% that had undergone an operation, the IAP 11%, and the European 9%. So all of them, when applied to a patient population, will avoid unnecessary operations, but to a different extent. Here's the kicker. When you look at missed high-grade dysplasia and cancer, the AGA guidelines missed 12%, whereas the IAP and Europeans missed none. So again, which ones to use? It depends on your philosophy. It depends on the patient's philosophy. So in conclusion, all 3 guidelines are relevant. They have consistent recommendation for the vast majority of patients. Despite being claims of evidence-based, all really rely heavily on judgment and consensus. We currently lack the high-quality data on natural history. Now, these studies are ongoing, and we will soon have these data, and highly discriminative testing that Ajay was talking about earlier, and it's on the horizon, and this will improve our outcomes. Transformative changes to the guidelines will come with these advances, and they're on the horizon for the near future. So what to do in these gray areas? Well, it depends on your clinical judgment, and it depends on your philosophy, which are the guidelines to use. For the vast majority of the patients, all the guidelines are saying the same thing, and they should be followed. For those gray zones, again, judgment and the patient's wishes, your philosophy, knowing you can do the operation safely, should help guide your judgment. Evidence-based management will improve with scientific outcomes, and true evidence-based guidelines are on the horizon. But until then, much of medicine still remains an art. So thank you for your attention.
Christoph, thank you very much for your detailed comparison. Thank you. But I would like to ask you, although we have a number of big cohorts of cystic neoplasms, if I could ask, which is for you number 1 reason that we do not have solid and evidence and well-designed studies on that? And always we say we don't have evidence, we don't have evidence.
I think it's a process in evolution. I'm actually old enough to see how this has evolved. If you go back into the 90s, I can remember that at our institution, the philosophy was, we started seeing these cysts. It was a disease of modern medicine, and they were first described in the 80s, but we started seeing a lot of them in the 1990s because everybody was getting a CT scan. You walk into the emergency room with anything remotely related to the abdomen, you get a CT scan. So now we were seeing them, and we knew that they were precursors to cancer, so we were very aggressive about operating on them. It actually probably took 5 to 10 years as a community to realize that was probably too aggressive, and that's when we started reviewing the literature. That's when Masao Tanaka, Carlos Fernandez del Castillo started coming up with these guidelines. It took another 5 to 10 years to realize, as we started to do this, we don't have the evidence, and what type of evidence do we need? And so really things started maybe in around 2005, 2006, where actually the realization of the scope of the problem and the lack of evidence was recognized. Now that's been 10, 15 years. But here's the thing, probably one of the most important pieces of data is the natural history of IPMN. The only way we're going to know the natural history is to follow a population of patients for over 20 to 30 years and see what happens to them. Those populations are now being followed. We have a large cohort at our institution. There's other institutions and multi-institutional studies where they're following these cohorts. And that's one reason we don't have it. It's simply the time and when we started studying the problem. The other things is, well-designed studies. There actually are well-designed studies, the work by Ajay, the work by the Hopkins group, by many other groups, in which the right questions are being asked, molecular markers are being identified, but it's in the phase now where they need to be validated and applied to large populations to know what to do with them, and that too takes time. So those studies are ongoing. I really think that the natural history studies, some of these molecular marker validation studies in the next 5 years will really start to come out and change how we manage this, and they will truly be more evidence-based. I think that, the reason we have 3 guidelines is because there's so much opinion. When opinion starts to go away and is replaced by fact, I think really there's going to be one set of guidelines for the management of these.
Thank you. So thank you very much.
Can I just ask a supplementary one, Dr. Wolfgang? You talked about new evidence coming on the horizon, and we've had some great examples of the evolving science. Are we well enough organized at the moment? Have we set up the sort of multi-center studies that are necessary over the long term to answer the questions, or are we still a little bit too siloed here? And who's taking the leadership here to really bring it all together?
I mean, I still think that we're too siloed. I think we should almost look at this as a world population. Exactly. Dr. Zhang is has an amazing group put together in Asia with a large population. We have a high volume consortium with several high volume hospitals. There's the Vogelstein cyst fluid collection study. There's the Dutch. We actually have now big silos, but I think it's time to combine all of those silos into one, combine our databases, combine the cyst fluid, and make it available to all investigators.
Yeah, it would be sad, wouldn't it, in 5 years' time to say, if only we had.
Yeah. We're at risk of not. So.
Okay. Thank you very much.
Thank you.